Hello everybody, and thank you very much for inviting me to your away day. So what I'm going to talk about for the next half an hour is the project that I'm heading up in NUH, which we've now called the SISS project. Its previous working title was the Workforce Trauma Project. So a little bit about me is I'm a consultant clinical psychologist and I sit within the staff wellbeing team. I've been here since October, so it was initially a project that was going to run for 2 years, funded by the charities to support staff who might have encountered any incidents at work where they may become traumatised as a result of that. We've moved on a little bit. It's now a permanent fixture in the trust beyond the 2 years, the envisaged 2 years. So it gives us a little bit more scope to roll out something that is meaningful and effective across all of the trust to support staff who may have encountered a traumatic incident. So I'm going to talk generally about the project and then specifically about how it's going to run in the theatres area and how TRiM works. So a number of your colleagues who are on the call today are already invested in TRiM, have been trained as TRiM practitioners. So I'm hoping at the point at which we get to questions and discussion, they'll be able to jump in and help me out. Please put any comments in the chat or we'll have time at the end for any questions and discussion. Okay, so the background to trauma support in the NHS is it inevitably is a traumatic place to work because we are working with life and death situations, but also that we're patient facing, we're public facing, so any interactions in any field with the public can end up as a difficult interaction. So what we know about trauma is all trauma or potential trauma evokes some sort of reaction. We call this traumatic stress. This is not PTSD. PTSD cannot be diagnosed in the first 4 to 6 weeks after an incident. But what we find is that traumatic stress mimics PTSD. It doesn't mean that we're going to go on to develop PTSD, but it is what's called a traumatic stress reaction. Most people will spontaneously recover from a traumatic incident. And only between 3 and 10% go on to develop mental health difficulties. And again, not necessarily PTSD, often it's anxiety or depression. The key elements that we know that are important in recovery from exposure to a potentially traumatic event are feeling supported by the organisation in which you work, talking with friends and family, having good coping skills, having a fewer number of additional life stresses, and general good mental health at that point in time. So the purpose of the project is that we have a proactive approach. So it is not people, in effect, who are we do the intervention with. It's the event itself. So it's the event that qualifies for intervention, not the people. And I'll explain that a little bit more as we go through. So the purpose of doing it across the trust is that currently, like most trusts, I've rolled this out in 3 trusts now, often there's a sporadic and variable quality of what's called debriefing. So people say, yes, we do a debrief or psychological support across the trust. So we envisage that we have one central point that delivers a standardised evidence-based staff trauma support, and it has various links in, because obviously that's quite a complex process across various divisions. So different ways of linking into those areas. What do we know about trauma? Again, I could go on for hours about trauma, so I'm just going to quickly bring out some highlights. So PTSD is not the most common form of mental disorder after a traumatic event. What we know is, from the diagram you can see on the slide, is it's often a perfect storm. So it's not about resilience. How we are affected by trauma is not about resilience. It's not about how good we are at dealing with incidents. It's often about a number of factors that come together in a perfect storm. So it's there might be work-related stress in the background, home-related stress, and then the trauma on top, difficulties with mental health that have been ongoing. And that then affects our ability to function. And that is actually the key of PTSD. It's not about symptoms per se, it's about our ability to function afterwards. So it might be that we're just that particular day, there's a perfect storm of things. We've had a row with the wife, the dog's not well, it's a difficult day at work. There's been some difficulties at work that have been kind of leading up to it, and an incident occurs, and it doesn't matter how tough or how resilient we are, it just catches us unaware. Something to remember, I love this picture because we sometimes forget when we see on the news these big kind of traumatic events that counsellors rush in and everybody's going to be traumatised and things. But actually, how we perceive a trauma is often the key factor for how we respond to it. So if we look at that, I'm sure it's photoshopped, but the pilot's view of what's going on is very different from the diver hanging off the ladder. And when they get back to base, they're going to have a very different view of what happened. So it's really important to remember that we all have a different perspective of what's happened and a different reaction. So why do we want to support staff who've been through a potentially traumatic event? Because we know from the evidence base that the impact will be less if we support straight away in the correct way. It's normal to have that traumatic stress response, so normalising the reactions, encouraging the natural recovery process back to those key issues of feeling supported, talking with family and friends. So encouraging all of that and reminding people to do the things that support them, and restoring that adaptive function. And then one of the things that we do as part of that response is determine the need for any further supportive services or therapy. So people don't go on for years and years and years with an event in their past that keeps coming back to haunt them, that we get them the right support at the right time. So what do people need post-incident? And I've broken it down to sort of 4 things or phases. So there's a preparation phase, the immediate support, same shift support, interim support in the first 48 hours, and then that kind of 4 to 6 week support window that we talked about that kind of gets in the way of the PTSD developing. So a little bit about preparation. I don't want to spend too much time on this. It's really good to just have a general idea of how we're going to deal with every single shift, regardless of how difficult it was or how easy it was. So making sure that we go home healthy at the end of a shift. Those posters you've seen around the hospital that were produced during COVID, that going home checklist, still useful to be doing. So making sure that there's a demarcation between work and home, and that we switch off, and we have a system in place that helps us to do that. And that's true for all of us, and that we support colleagues to do that. It's good preventative work to have an incident or crisis plan, have a clear process that's consistent. So if we have a difficulty in the shift, what do we do? So some questions that we might ask as part of that plan is, who needs to know? Is everyone okay? Is everybody physically okay? Do we do a factual rundown or a hot debrief? Checking in with everybody. And some of those checking questions, such as, who's going to be at home when they get home? What are they going to eat? Have they got a meal ready? How are they getting home? When are they next on shift? And are we going to do any support like SISS or TRiM? And then who's looking after the managers? Often it's really hard to support all of the other staff. So making sure that we as leaders are looked after as well if we're supporting other staff. So I'm often asked about the role of debriefing. So I just want to say a little bit about that. So there's a lot of literature around. There's 3 types of debriefing that the literature talks about. There's operational, psychological, and something called CISM or CISD, which stands for Critical Incident Stress Management or Stress Debrief. Operational debriefing is generally what you will all do anyway, that kind of the learning points, the factual debrief, what happened and what do we need to learn in the moment, the mortality meetings, that kind of thing will be that factual learning where we are understanding what happened and is there anything that we need to immediately do to prevent it happening again. That's really useful. And anecdotally, when I'm working with staff, that kind of factual understanding the decision-making process and what actually happened is really useful, and it is it does help people understand, and it decreases some of that emotional content. And what we're looking to do when we support staff post-incident is reduce the emotional loading of that. You'll see a lot about psychological debriefing. It's not recommended. There is not a good evidence base for it. There are certain types of psychological support that are useful after an event, but a psychological debrief as kind of delivered in the past doesn't have a good evidence base, so we don't recommend it. CISD, that kind of critical incident stress debriefing, is recommended. It's a very particular structured way of running a group, of facilitating a group of people who've been through the same incident. And we offer that as part of the SISS service in NUH. So we've done the immediate support. Is everybody okay leaving shift? Then for that first 48 hours, what's really useful is something called psychological first aid. Within the staff wellbeing team, we run workshops on psychological first aid, which you're more than welcome to join. And we also are aiming to put that online, so you'll be able to access it online come August. And that describes 7 helping actions that we know are evidence-based, that are really useful for people to have following any kind of distress. So this is not mental health first aid training. This is about emotional support when people are distressed. So we're caring for their immediate needs, protecting them from further injury, comfort and console, supporting them to get anything that they need. So do they need to call somebody? For example, if they've had some bad news on shift, can we call somebody? Can we help you call somebody? Providing information. It's not unusual to feel distressed in this situation. We talked about the importance of connecting with people. So connecting with somebody who's distressed, making sure that they are linked into their normal support mechanisms, and educate them about what's gone on. So again, that you can see the link that we've got with the facts of the event. So anything that we can do to help them understand the situation or understand their reactions to it. And centrally important to that is back to looking after ourselves when we support other people. So that psychological first aid is really, really important because it helps people to, again, reduce that emotional load, reduce the cognitive impact of the event, and helps us to just kind of start to access those normal, natural coping responses. So the fourth sort of stage that was on my little diagram is what people need. So after the first 48 hours, do we need to think about whether there needs a slightly more formal support? So that would be the SISS service, which it stands for Significant Incident Staff Support, and as part of that, TRiM sits under that. So the process would be: an incident occurs, we do the immediate post-incident support, so whether that's psychological first aid or check-in, a kind of good check-in with people, we do that immediately. And then whoever's in charge might make a decision to refer to SISS. Sometimes you will, sometimes you won't. It very much depends. Again, we'll talk at the end about the criteria for theatres. What sort of things do you want to refer into the SISS service? What sort of things need formal support? And then once the referral is made to the SISS team, they'll triage the event, decide what is necessary in conjunction with whoever's done the referral. And then we'll have initial intervention, which will either be the CIS MOD or TRiM. And that happens within the first 7 days after an incident. And remember, it's the incident that is, if you like, trimmed or responded to. It's not the individuals, although it's actually done to the individuals. It's the event that we categorise as a critical incident requiring support. And then 4 to 6 weeks afterwards, there's a follow-up, either a follow-up TRiM chat or a follow-up CISD group or individual follow-up, just to check that everybody is recovering as we would expect, and for those that are not, that we are helping them to access some further support. But that's the end of the process. So that 4 to 6 weeks is key because that's when we know the PTSD is or other mental health difficulties are likely to show up. So if we are thinking about a referral to the SISS service, there's two options. So TRiM is what we have in theatres, and CIS MOD is what we provide through chaplaincy and clinical psychology across the trust. So in theatres, you have access to both options. So we might decide, so for example, in the past week, we've had a number of incidents. One of those in an area in the trust has had so many people involved, we wouldn't have TRiM capacity to manage that. So we've gone down the CISD route to do some groups. Whereas we've had an incident this week where one person was involved. So actually that makes much more sense to do TRiM. So perhaps it's sometimes numbers that will help us decide which route to go down. Sometimes it's about the type of incident and whether there's a homogenous group or a number of incidents and so on and so forth. So you have clinical psychologists helping you to make that decision alongside the referrer of which route we go. So I'll talk a little bit more about TRiM because that's the one that you will become more familiar with in theatres because you've been really proactive as a department in looking at TRiM and getting that off the ground. So TRiM stands for Trauma Risk Management. It comes from the military and it's a peer support system designed to help people who've been through one of these potentially traumatic events. It's based on that idea that most people spontaneously recover and that most problems show up in the first 4 to 6 weeks. So it's based on a model of watchful waiting and it's carried out by trained individuals who have had a specific training in TRiM and how to support people post-trauma. It's a structured chat, it's a structured assessment, a risk assessment, but it is very informal. It's a talk with a colleague and it's done in a particular way that looks at confidentiality and is not part of any investigation. None of the information that's taken during a TRiM chat can be used. It can't be accessed by anybody in the trust and the governance around that is really strict. So it's purely to ensure that staff get the correct support that they need. So if you were invited to a TRiM chat or you're going to be a TRiM practitioner and you want to carry out a TRiM chat, what does that look like? So it's a 45-minute to an hour structured conversation with a TRiM practitioner for everybody who was involved in a particular incident. So as I said before, it's not the people, you're not waiting for somebody to fall off their perch before they have a TRiM chat. It is, we have had an event. So everybody who is involved in that event will be offered a TRiM chat. They are not compulsory. You don't have to attend, but everybody is invited. So it's a really proactive process and we just pair people up with a TRiM practitioner and they have an initial 45-minute to an hour structured chat with people. So the TRiM practitioners are colleagues. We have a central pool within the staff wellbeing team as well. So it might be that you get partnered with somebody who is not part of the department. There's some positives and negatives to that. So we have a mix that we can pull on. And colleagues have been selected because they're interested in helping, they're good with confidentiality, they have good listening skills. So they carry out the TRiM chats in a friendly and non-stigmatizing way. It's not a mental health chat. It is about, this is what normally happens after trauma. These are the normal reactions. And can we ensure that you're doing the things that you need to do in terms of support? So then once you've had your TRiM chat in the first 7 days, then 4 to 6 weeks later, the same person will come back and repeat the process. It won't be as detailed because there'll be bits of it, sections of it that they don't need to do because they've already done it. Just to check how you're doing and check your scores against your previous ones to ensure that there's no lingering psychological or emotional impact of the trauma. So this is great. We've decided that we're going to run TRiM in theatres. So if we had a critical incident or something that we decide is a potentially traumatic event, what do you need to do? Well, It's fairly simple, really. We have an inbox, which is sis@nuh.nhs.uk. So you can make a referral into that. You can talk to one of your local TRiM practitioners about how to access the service. There's lots of ways in. You can email me direct. And it's really simple. The information we need is just what the event was, really brief synopsis, and the names and the contact details of people who were involved. And we do the rest. We'll have a quick chat with you as the referrer, and then contact everybody who is involved, offering them a TRiM chat, partnering them up with a TRiM practitioner, and then people can choose whether they attend or not. Most people who attend find it really helpful because it's an opportunity to talk through what happened in a really safe space, and that helps. In my experience, anecdotally, that helps. It is a bit of a debrief. It helps that kind of processing, because we're making it into a narrative. Often we find that people who go on to develop difficulties after an event have often become fixated on one particular issue or aspect of the trauma, and that's the bit that they have kind of flashbacks about, and so on and so forth. But actually, by helping somebody to talk through in a coherent way and produce a narrative about what happened to them, it starts that kind of recovery process and the processing of what happened, and it aids that recovery. So really simple. Tell us who was involved, what the incident was, and we'll support to do all of the rest. And we do all the logistics around that and get people partnered up with a TRiM practitioner. If we decide it's going to be a SISM group, again, we do all the logistics around that. We'll produce a clinical psychologist and a chaplain and a venue, or we'll support you to find a venue to run the group. And the only thing that managers or leaders need to do in the area is to make sure that people are released from shift or brought back in and paid for their time to come in to do the group debrief. So that was a really quick whistle-stop tour through the project, the SISS project, and how TRiM sits under that, and TRiM in theatres. We're in the process of deciding which incidents we're going to categorise as TRiM incidents in theatres, and then our due go live date is the 1st of September. But because we already have our practitioners in place, we're in a bit of a soft launch. So if you have any incidents, or probably if anybody's had any incidents recently, you'll know that we are already supporting staff. So whilst we'll have a big launch and a go live on the 1st of September, we're in kind of soft launch while we get all of our TRiM practitioners trained, validated and ready to go. So that gives us plenty of time for any questions or comments, because I'm sure there'll be lots.